So I'll start my lecture now. A space occupying lesion is, if you know, it's straightforward. It's a focal lesion, and you have two varieties. One is that you get a incidentally diagnosed thing where you do ultrasound scan for some other reason, and then you happen to see a lesion. The common presentation is when a patient comes to you, you investigate him on certain lines, and then you will detect a liver lesion. So those are the two possibilities, two ways that one can present to you. Right. Now, if you look at incidental liver lesions, now the incidence is getting higher and higher because of free usage of ultrasound scan, and even the CT has become one of the main line of investigations, and it's readily available. So because of that, this incidence have gone up. They say about 33%, and actually we don't know whether in the population it is so, but the recent studies show that about 50% of the autopsy studies done in the recent past shows that there are lesions in the liver which was undiagnosed. So this bit of demography, don't worry, I'm not going to talk about these these percentages and all that down the line. Just to recap your knowledge on these liver lesions, now these are the common ones. Now you don't have to remember, just remember, in the medical student days we know that it's malignant lesions and benign lesions, and there are cystic lesions and there are solid lesions. So these are the ways of categorizing. So these are some of the common benign lesions. You can see on the left hand side, you can see some cystic lesions, hemangiomas and hepatic adenomas and hematomas, which are common benign lesions. And if you can remember malignant lesion, if you can remember hepatocellular carcinoma and metastasis being one of the commonest things, that is more than enough. And then intrahepatic cholangiocarcinomas, it's within the liver capsule, right? This is the basic pathological classification, but what we see is in the ultrasound scan, we will get a report like saying whether it's a cystic lesion or a solid lesion. So that's where we usually start our thinking process or investigation process. So what do we have to do then? It's a multidisciplinary approach that you need the radiologist's input, you need a surgical input as well as physician's input, but even general practice also you can get involved, and because most of these lesions can be managed in the once a diagnosis is made, it can easily be managed in the GP system where they need regular follow-up. So because of that, everybody should get involved, and most of the time what happens is when the diagnosis is made, even a benign lesion patient tends to come back to the hospital, where most of these patients can be actually discharged back to the clinics where they can be followed up in the clinics, because some of these lesions are really benign and we don't have to worry much, right? Okay, so whenever we see, I don't have to tell that careful history and examination is mandatory, because it makes a huge difference in your management as well as approach to the diagnosis, right? And most of these lesions nowadays can be easily diagnosed with a certainty with imaging facilities. Ultrasound scans are better now, CT scans are available, and MRI. So by these things, most of the lesions can be diagnosed. Now, cytological diagnosis and histological diagnosis is slightly falling out of flavor because there are, one thing is that it has some complication rates, and other thing is that since the imaging modality is very sensitive and specific, you can just depend on the imaging facilities. But certainly there are certain situations where we need to do cytological and histological imaging. I will when it comes, I'll have a chat with you. Right. So now, in the history and examination, why we want the history and examination is to identify this patient's risk category, whether they fall into a kind of higher risk group with a liver lesion, or whether they are with a low risk group. So now high risk group categories are like patients who are having chronic hepatitis. There's a long list, right? Everybody can understand. So just when you're taking a history, if you just happen to notice that any of these things are there, like a hyperlipid lipidemia patient with even fatty livers changes, or any patient with cirrhosis, so these patients fall into a high risk category where we have to be a bit concerned about these patients with liver lesions. Yeah, and these are some of the, this is not important, I think this is good for a medical student. When you have chronic liver disease, these are some of the some of the clinical features that we see, which I don't want to go into detail because most of the people here are seniors. So then you get into the low risk category where there is, in the history of the patient, if you take the history of the patient, there is no malignancy in the past, there is no chronic liver pathology, or probably maybe a younger age group, right? These patients fall into low risk category. So we can kind of ease off from these patients, right? And next important thing when you are assessing is the size of the lesion. Now, size of the lesion, less than 1 centimeter lesions, actually you don't have to worry much, right? Especially if they fall into low risk category. And if the patient is having any other risk factors which I mentioned earlier, then you must consider them again to review, or else have a MRI or some sort of imaging. MRI is the recommended thing, but some sort of imaging at our level, again in about 3 to 4 months time, to see whether there's any change in the lesion. 1.1 centimeter, more than 1 centimeter lesions, if it can clearly demonstrate that it's a benign lesion, we don't have to actually follow them up, right? Because some of the lesions, even with ultrasound scan, they can with a certainty they can say that it's a benign lesion. In those situations, you don't have to follow them up. But if suspicious, always recommend MRI. This is consider MRI in the Western. I think we can even go for a contrast and CT because of the availability. We can use that. But the recommended thing is to liver. Usually, we go for MRI scans, right? More than 1.5 centimeters, irrespective of the risk category, it is better to evaluate them properly. So whatever the imaging modalities that you have to image them properly, preferably a MRI or a contrast enhanced CT scan, and we have to categorize these lesions. We have to make sure that this is we have to confirm that it's a benign lesion, or we have to somehow know what it is actually. We can't just ignore the lesions, right? Now this is the flow chart. Nobody can remember this flow chart. I just put the flow chart, right? Now with the imaging, we are not radiologists, so there are a few radiologists, but as a physician or as a doctor, the things that we can grasp from ultrasound scan is we can know whether it is solid or cystic. We can look at the vascularity of these lesions. They will tell us the vascularity and the echogenicity of the remaining liver. So that will also give us a clue whether it's a cirrhotic background, whether it's a fatty background, whether it's a normal liver. Right, and ultrasound scan is also very important in monitoring these lesions, right? Because it's a less invasive and freely available, so most of the time, most of these liver lesions are monitored through ultrasound scan. So that is why I said we can actually manage them in the periphery or as a GP setting once we diagnose them as a benign lesion, and then we can actually discharge them with regular imaging to be reviewed by a doctor. The contrast enhanced CT scan is another readily available thing, and then it's commonly used in Sri Lanka. For us, we have contrast enhanced CT. That's the maximum we have in certain situations. So, in contrast enhanced CT scan, when you're assessing liver lesions, we have to have these 3 phases actually. So, unless you have these 3 phases, it's very difficult to get into a kind of make a diagnosis. So, simply it's like arterial phase, very early phase, within 15 seconds you have to do it, or else there's another phase called portovenous. So these 3 phases are important. They will go through these 3 phases and tell us the diagnosis, right? And MRI also will be very helpful. That is the recommended thing for most of the liver lesions. But actually speaking, it's very difficult for a normal. For me also, it's very difficult to interpret these results unless you are a proper trained radiologist in MRI. Very difficult to interpret results. There are T1 and T2. Only thing that I can remember is T2 being water, so H2O and T2 water, so your MRCP films are better in T2. But it's very difficult, but this is one of the best modalities in evaluating liver lesions, right? And next thing that is readily available for us is tumor markers. With the imaging facility, we can always use these are the 3 tumor markers that we use, especially in the lesions with liver. alpha fetoprotein levels, especially we are thinking of a hepatocellular carcinoma, and CEA levels in colorectal metastasis, and CA 99 if you are suspecting something in the liver, intrahepatic cholangiocarcinoma. So these are the three. So these also will be helpful in your assessment of these lesions. Now, just so if you go by this pathology of the lesions, if I take the solid lesions, I will quickly go through some of the common solid lesions in the liver that we see. Hemangioma is one of the commonest lesion, and it's seen about 20% of the cases. And usually they are asymptomatic, usually small, right? But if they are bigger than 4 centimeters, usually we call them giant hemangiomas. But actually we see larger ones, about 10 to 20 centimeters in size, right? These are the ones which causes symptoms, symptoms mean like they will have very vague pains because of the these big lesions can stretch the capsule and cause some pain, some discomfort, and sometimes they can even cause bleeding. So these are the clinically, if they come, these are the symptoms. If they are going to have a symptom, these are the symptoms that they will have. And this thrombocytopenia is usually seen in lesions which are very big, because all these hemangiomas are cavernous type of hemangiomas. So there can be some thrombosis inside, and then patients platelet counts can come down, right? And there's a risk of spontaneous rupture, which is very rare, but it is been documented in certain places. So because of that very big lesions, we are worried about a rupture also, especially in the surface hemangiomas.